Thank you for being part of Multiple Sclerosis News Today, official coverage of CMSC 16, and to agreeing to this filmed interview. Clinical trials assessing ocrelizumab have shown that it is a promising, effective therapy for MS, being able to reduce disease relapses, disability progression, and disease-associated demyelinating lesions. How do these clinical outcomes reflect in the overall well-being and quality of life of the MS patients enrolled in these trials?
So this is a very important question, and as you've noted, ocrelizumab in two very large double-blind, double-dummy studies against interferon in relapsing MS resulted in reductions in three major markers of disease: relapses, inflammatory lesions on MRI, and confirmed disability progression. It's quite well established in the literature that disability progression or advancing disability is associated with declines in quality of life, as well as the ability to maintain employment. And in these two ocrelizumab relapsing MS studies, there was a 40% reduction in disability progression compared to interferon beta 1A. So a very important and meaningful result.
In the particular case of PPMS patients, the results obtained with OCRB are highly significant given the condition poses an important unmet medical need. Are the positive results being demonstrated a surprise, perhaps in their degree, given that so many other efforts in PPMS have failed?
So I would not say that the results are surprising because the study was designed with a specific hypothesis in mind. The thinking at the time was that B cells might be important in MS in general, including both relapsing MS and primary progressive MS. And so that was the reason the study was done. Our approach to designing the study was important because, as you know, there are no approved therapies, there are no successful clinical trials in primary progressive MS. So it wasn't an easy task to design or wasn't an automatic task, I should say, to design a clinical trial that might show a therapeutic effect. So it's not surprising, but it is an acknowledgement of sort of how much we've learned about PPMS, and also an acknowledgement that the B cells probably are important in driving the disease, including in primary progressive MS.
Regarding the safety profile of ocrelizumab, were there major adverse events reported so far? And if so, do these differ between patients with relapsing forms of MS and patients with PPMS?
So there have been 3 phase 3 clinical trials, the 2 OPERA studies in relapsing MS comparing ocrelizumab to interferon beta 1A. And in those 2 phase 3 studies, the overall adverse event profile for ocrelizumab was generally similar to the interferon. So the proportion of patients who experienced any adverse event was comparable between the two, and the proportion who experienced any serious adverse events was also similar between the two, and that includes serious infections. In the oratorio study in PPMS, we saw a similar picture, where the overall safety profile was generally similar to placebo. The proportion of patients with any adverse event was similar between ocrelizumab and placebo, and the proportion with any serious adverse event was similar between ocrelizumab and placebo.
Concerning the therapeutic approach, ocrelizumab is an antibody that selectively targets B cells, which play a central role in MS pathogenesis. However, some suggest that targeting only B cells and excluding, for instance, T cells as therapeutic targets might not be the best approach. What are your thoughts concerning this controversy?
I wouldn't call it a controversy. I think in the last 10 years or so, there's a recognition that B cells are much more important in driving the disease or the pathogenesis of MS than was previously believed. And ocrelizumab is a therapy that specifically targets a subset of B cells that express the CD20 antigen. So it preserves stem cells, which are the progenitors of cells that become B cells, and it also preserves plasma cells because they don't express this CD20 antigen. And that's important because plasma cells are the cells that secrete antibodies. Now, B cells are known to interact with T cells, and they're both part of the adaptive immune system. And our thinking, and the scientific field's thinking, is that B cells are probably working in concert with T cells to result in inflammatory lesions, relapses, and the subsequent disability progression that occurs. So while it's true that ocrelizumab specifically targets B cells, which is a very, excuse me, let me start that one again. While it's true that ocrelizumab specifically targets B cells, that specificity has certain advantages, because you're right, it does not specifically target T cells. However, it's targeting B cells that are probably interacting with T cells to make the disease worse. And so it's not that T cells are entirely unaffected. At least that's the thinking in terms of how the drug is working.
The US FDA recently granted ocrelizumab the breakthrough therapy designation based on the positive clinical trial results disclosed so far. Can you comment on Genentech's future plans for the drug in terms of approval by regulatory authorities and marketing authorizations?
So I can't comment specifically on approval because that's under the purview of the regulatory agencies themselves. What I can say is that we are working very diligently, as hard as we can, to file the application for marketing authorization in the first half of this year, and are very committed to hopefully securing approval as fast as possible, recognizing the high degree of unmet medical need.
Okay. Thank you very much.
Okay, thank you.